Yes, ma'am.
Perfect. Okay, well, welcome everybody. We are going to go ahead and get started. Welcome to the Infant Early Childhood Mental Health Statewide Tour Report Community Presentation, March 2024. We have a packed agenda today, so here are some housekeeping for you. You're going to be automatically muted to prevent background noise. If you are running into any technical issues, please send a chat directly to Genevieve de la Cruz. She's our admin here with us today. If you need live closed captions, you can click the button at the bottom of your screen to show captions. And if you want to react to anything you see on the screen, you can feel free to use the reaction emoji button. We may get into this a little bit later when we do the agenda, but we have a short time today, and so we probably won't be able to take any time to address your questions now. But if you do have questions that come up, please feel free to put them in the chat, and we may be able to respond later on in the year. So here's our agenda. We're going to start with some welcome and introductions. We're going to go over making a case for infant and early childhood mental health, our key findings from the report, and what's next. There have been some reflective prompts that were brought to you by providers throughout. And so when we get to those sections that are meant to help you reflect on the findings, if you could just put your responses in the chat, and that will also help us to know how this is landing for you all. We will also have some time at our next office hours to respond to questions. And if you registered for this webinar today, you'll get a link to that in the future. And with that, I will start with some introductions for myself and pass it over to Christine. I am Kiki Fabian, work at the Healthcare Authority as our Infant Early Childhood Mental Health Analyst. I've been here at HCA for over 3 years now, and I really love getting to work with providers and families on how we can improve our system, as well as any opportunity to use data to make data-informed decisions about how we build a better future for tomorrow. And I will pass it over to Christine.
Thanks, Kiki. Welcome, everyone. I'm Christine Cole. I know a lot of the names on here. I work as our Infant and Early Childhood Mental Health Program Manager here at the Healthcare Authority. I'm housed in a different section than Kiki. That's called Clinical Quality Care Transformation. But I think almost everything that I do is in partnership with Kiki. There's very few things that are not, so I'm very fortunate to have our dynamic duo supporting this work. I've been at the Healthcare Authority for coming up on 3 years, I think, in like a matter of weeks. And I bring experience as a provider doing direct practice in community mental health in Colorado. And I've also supported and supervised teams around infant and early childhood mental health consultation in Colorado and California. And I get to bring that into my work here at HCA. And because we have a short amount of time, I'm going to just keep going, and because otherwise I could talk forever. So thanks, Kiki. We encourage you to put some information in the chat. We know that you registered already, and it's helpful for Kiki and I to see who's with us today, what role or organizations you support, and if there's anything that you hope to learn from today. Hopefully we will touch on it, and if we don't, like Kiki mentioned, we'll be circling back during our office hours. This is something that we often do as a part of our practice, and how we support infant and early childhood mental health in Washington is that we address the things we can in the moment. And when we need to take things back, we use those to then inform our future learning opportunities, as well as our billing guidance and policies. And so you sharing what you hope to learn or questions you have actually helps us to strengthen our work. And so we really appreciate that. And so feel free to put that in the chat. I know that Kiki and I will keep an eye on it. And Kiki, is there anything else that you want to add around getting to know you before I jump into content?
I don't think so, but I do see a note here that I am supposed to share the link to the report at this point, which I don't have access to because all of my screens are taken up by our many technological devices. So if you would be able to share that link, you'll see in the slides that we've added little goalposts so you can see where in the report we're at if you want to follow along.
Thanks, Kiki. Perfect. And thank you for getting us started, everybody. All right. Before we jumped into our findings, we thought that it would be a nice little moment to pause and just recognize that this work did not happen with Kiki and I alone. This was really the culmination of partnership with a lot of folks across our state, both folks who work at the Healthcare Authority and then others who actually represent a whole host of different systems partners, from tribes to public health, direct practice providers. And Kiki and I, honestly, I think both of us will probably get teary if I talk too long about this. It just was really a special experience to see something that was just an idea for Kiki and I culminate and transform into this collaborative shared project that really looked completely different across the state, and has some really powerful perspectives and voices represented. And so we just wanted to take a moment to acknowledge that this work is not Kiki's and my work, but is really held by those that are represented on the screen here today, and a host of many, many others across the state who spent a lot of time with us over the summer to share their perspectives about what we can do to help young children in Washington. And so thank you. And without further ado, we will jump into our content for today. So we focus on infant and early childhood mental health, and this is really a newer opportunity in Washington state. As Kiki and I both mentioned, our roles have only been here for the last few years, but HCA has really taken strides with the support of partners across the state to really help build capacity for what we're doing to support infant and early childhood mental health. And the reason that we think that this is important as HCA, and I'm sure to many of you, is that we know that this time period in the birth to 5 and prenatally, honestly, as well, is really critical to us creating a strong foundation, not just for folks being able to manage their emotions and mental health and their relationships in the birth to 5 years, but that we know that this is critically important for creating a pathway for health and resiliency throughout their lifetime. And so we just wanted to make sure that for folks who might not be as familiar with infant and early childhood mental health, to share this context for why we think this is a really important area for us to focus on. Next slide, Kiki. We're fortunate because the folks that we worked with over the summer really agree that this is a critically important time. Some of the pieces here that you'll see, the data points, are from reports that Kiki has actually worked on. We know that children birth to 5 have at least, there's 1 in 5 kiddos have a mental, behavioral health, or developmental disorder. Side note, Kiki did not do that research, but we use it a lot. And we think that this data is probably a little bit outdated. But when we think about those kiddos, of the kids in Washington that are birth to 5 who have a mental health identified need, about 50% of them are actually receive services. And thinking about who offers those services, we have licensed behavioral health agencies in our state. They are not the only providers of mental health services, but they provide a lot of services to folks, especially those enrolled in Apple Health Medicaid. And about 1 out of 3 serve children under 6, and only 8% serve children under 3. And so this is really important when we look at the quotes that we have represented throughout the slide, highlighting providers' perspectives. Our providers that we met with really highlighted the need for offering more services. There are not a lot of places that kiddos under 5 and especially under 3 can get care. And so many providers identified this and said, we need to fill that gap. We also had folks that recognized, like we shared on the last slide, that there's a strong return on investment and a benefit for us working with young children earlier, instead of waiting until needs have kind of gone unmet or maybe worsened over time in later elementary school, middle school, high school, and even sometimes after. We also had folks that really highlighted the importance of agency support, that if we want to make this happen, if we want more behavioral health agencies or more organizations in general serving birth to 5, that it's really important to have upper leadership support to make that a reality. And with that, we will transition into our key findings, which we have 7 core themes that I'll let Kiki talk a little bit more. And as we go through the slides, similar to the report, these were things that we saw across all of our sessions, our listening sessions with folks. And so all of the topics are representative of the state, and that folks really honed in on these areas. Kiki?
Thanks, Christine. And yes, you can see on our screen, here's our 7 big topics. A lot of things covered multiple topics. So if you do a deep dive into the report, you'll see the different threads we've woven to connect financing to mental health treatment and workforce to caregiver engagement. And we do just want to make sure we're clear with everyone that we're not going to do a deep dive into every finding from the report. We had hundreds and hundreds of quotes from providers, many different themes. And today is really going to go over the highlights. But we are going to go through the highlights kind of in this order around these themes. Anything else you'd add, Christine?
No, perfect.
So let's get started with workforce. If you're looking at the report, we're going to be starting on page 15. We first want to talk about who even is the infant early childhood mental health workforce. We've got a great graphic here on the side that talks about the fact that infant and early childhood mental health, like mental health for everyone, exists on a spectrum. We all have mental health, and sometimes we only think about mental health in terms of a problem or an issue, and that is what we focus on a lot in our role. But we want to acknowledge that it really does exist on a spectrum, and anyone who's in a relationship with a young child plays a part in their mental health and well-being. Not that this is not true for older children, youth, and adults, but being able to serve kiddos across disciplines, across domains is really key for young children. And so when we think about the workforce, we're not just thinking of mental health counselors or psychologists. We're really thinking about all of the professions who are in a helping role working with young children and their families and communities. That being said, our tour really did focus on these providers who are kind of in the top of this pyramid, the assessment and the treatment piece, who are mental health professionals, mental health providers, working with children enrolled in Apple Health. Christine and I talk a lot about the importance of doing things in developmental steps because that's a part of infant early childhood mental health work, whether you are working with a family or working in policy. And so we do want to acknowledge that this is just a piece of the puzzle, but it helps us take a first step towards understanding the broader workforce. So what did we find? Throughout the report, we tried to highlight kind of two sides of every coin. What are the best practices that people shared are really working that we can learn from one another and grow and build on, as well as some of the challenges and the needs that we still have in our system. So in terms of building a strong workforce, providers elevated a number of different ways that they've seen this really working in terms of recruitment, retention, and building on professional skills. Having dedicated infant early childhood mental health teams, support from supervisors who have training in infant and early childhood mental health, reflective supervision and consultation, internships, communities of practice, and specialty programs at institutions of higher education were all noted as really key strategies for building a workforce. Another thing that was raised by a number of providers was the importance of centering diversity, equity, inclusion, and workforce development. We know that our population of children who are getting services is very diverse, and they're going to have needs that may be best met by providers who look like them, who speak like them, who understand their experience. And even in cases where that's not true, there's learning that we can all do around how to incorporate diversity, equity, inclusion into our work, because no matter who you are or what your background is, your culture, your perspective is going to play an impact in your mental health and well-being. The providers shared that really emphasizing that component, both in their hiring practices and their professional development practices, is really key in building a strong workforce. And I don't know if we share this explicitly, but while we're on this slide, I'll pause to say that these things that are in clouds and in quotes, these are the direct words and stories of the providers we met with. And so we're not going to necessarily read them out to you all today, but we wanted to make sure to highlight them so that their voices can really shine through. While we did hear a lot about the different strengths, we also heard that there are some challenges that people are facing. These challenges are happening within the context of a kind of broader behavioral health workforce shortage. People were really clear with us that this isn't an infant early childhood mental health problem specifically. In some cases, people actually said their infant early childhood mental health teams had the best retention of all their different providers. But there are special things that impact infant and early childhood mental health providers. There's often not a lot of training in infant and early childhood mental health in higher education. So folks are coming into the field, maybe not with a lot of skills, or maybe not with a lot of confidence. They may actually have the skills, but don't know how to translate what they learned in school working with an older child to work with parents and young children. And Christine probably has some good stories from her experience, but sometimes people don't even know that they might be interested in this work until they get started doing it. It may not be the thing that comes to mind when you think about being a mental health provider, and until you get into it, you might not experience how fun, exciting, and rewarding this work can be. Given these different challenges, one of the top desires that people shared was the need for more infant early childhood mental health specialty training and professional development support. We've got a lot of great work that's happening in our state around this, but there's still more to be done. And even when there are things that are offered, there may still be barriers to accessing those opportunities, such as the expense involved with paying for training or getting release time. And before I transition to the next slide, I just wanted to note one other thing on this slide, which is that at the end of every listening session, we did ask people, if you could pick one thing to wave your magic wand and come away with, what would that be? And we've noted those here with this little top desire flag. So if this is something that people said, ooh, this is the one thing that I want, we flagged that here. So you can see that both of these were things that came up for folks as their top point. Oh, let me go back. Christine, anything you'd add here?
You're doing great, Kiki.
All right, well, I will pass this over to Christine to get us started with our first reflecting together.
Yes, and so like Kiki shared at the beginning, we also have reflective moments that we hope you'll participate in. These, when they're italicized, mean that they came directly from participants and things that they're continuing to think about and elevate as things for us to consider as we continue to build out systems for young children. And so if you feel so inclined, we'd love to hear in the chat about as we develop a birth to five capacity, what core competencies would we want to see for staff working with birth to five teams? Which trainings would we want to prioritize for our birth to five staff? And this is really reflective of folks talking about, like, even if I wanted to start getting folks trained, like, what training should I even be focusing on? Like, what are the core pieces that are foundational to us working with young children? Folks also, our other one says, I'm a parent too, so I know there's a really strong need for these services. What would it take to get more people interested in the field? And we would love to hear this to understand for you or from folks that you work with, what got folks interested? Like, what were the levers and motivations that we could leverage to get folks connected to us? All right, Kiki. And I love to see folks already adding to the chat. Thank you so much. It looks like folks are already, Kiki, highlighting diversity, equity, and inclusion, trauma-informed care, caregiving dimensions. So please keep those coming. We really appreciate it. We are doing great on time, Kiki, but I think we can go to mental health assessment for young children. So mental health assessment for young children, or MACI, as Kiki and I lovingly call it, is really a core foundation to our work. When we both came to Washington, there was already advocacy underway to think about how we might do assessments differently when we're working with children birth to 5. And when I started about 3 years ago, it was right after legislation had passed that changed our Apple Health Medicaid policies. We're going to briefly talk about it here. And if you're interested in understanding how this happens in practice, we would encourage you to come to our billing webinar where we talk more in depth about the codes and the mechanisms for getting these different opportunities for you or your organization. But this is a critical piece that we wanted to explore to say, we set this up, but how is it going? And so the policy included 3 main parts. It allowed for reimbursement for multiple assessment sessions. So rather than just having one biopsychosocial assessment or intake session, folks are now allowed to use up to 5 sessions when working with young kiddos. It allowed for reimbursement, so folks could offer these sessions in home and community settings to keep kiddos in their natural environment with their caregivers. And it also included language around requiring the use of the DC 0 to 5, which is in some ways similar to the DSM, which is used for older adults and youth, but it has more developmentally appropriate diagnoses for young children. We also included this visual here because though the DC 0 to 5 has its own axes of looking at medical and physical conditions and relationship and context, we wanted to translate to our broader system, recognizing that not everyone is familiar with our birth to 5 or infant and early childhood mental health space. and that a lot of the things that the DC 0 to 5 is asking folks to consider do align with what our broader health system for behavioral health is thinking about in terms of looking at needs and strengths, gathering history for the individual and their family, thinking about their context and their development over time, and whether or not they're participating in other types of care. And so this little pie chart just kind of elevates that though assessments for older adults and adolescents may look somewhat different, there is some alignment in terms of thinking about what are the main things that we need to understand when assessing young children that are similar to all people. Next slide, Kiki. And so we heard some great things about what folks are already doing to shift implementation for these policies. Though these things are highlighted as things folks are doing, folks have also elevated that these can sometimes be challenging as well. One of the biggest things noted is that there is just culture change that happens when we make these shifts around doing things differently. That just takes time. We are not just individuals working in a silo, and so often our organizations have a lot of things that are flowing in a certain way, and that it takes time helping orient folks around why we would want to change this, what's the benefit, how will this impact our work. And so folks just acknowledge that organizational culture is key in making this change, and it also takes time. It's not going to happen overnight. A more operational component of that is around changing workflows and scheduling. Folks said things like, well, we only schedule one assessment. And so then like, if we don't schedule all 5 at the beginning, then someone might not be able to get another assessment for a long time. And so having to think about reworking, like when we call in, if it's a kiddo birth to 5, do we schedule 5 sessions on that call, or do we just do 1? Or thinking about, does this go to our typical assessment team, or does this go to a specialty team? And that ties into the assessment staffing around recognizing that some folks have assessment as a part of their clinicians' jobs, whereas sometimes it's a dedicated team, and recognizing that sometimes those staff might not be as plugged in and might not be aware of DC 0 to 5 trainings and offerings. And so there's just a lot of pieces at an agency level that have to be considered to make this possible. This purple box is important to highlight because folks also talked a lot about engaging caregivers and supporting them through the process. Well, I think a lot of us here probably recognize that caregivers, if they're coming in to see us for an assessment, there probably have already been some challenges and needs going on. And my guess is they're feeling a little stressed. And so we might have to help them to understand why we're not just jumping in to giving them answers, and why we're taking the time to slow down and meet multiple times, and why we're observing them. So there's a lot of work to be done around helping to think about how do we talk to caregivers about this process and why we're doing it and what the benefit will be for them and their child. Next slide, please. We also heard some pieces that could be further expanded on to make this policy even better. We'll also talk a little bit more about travel and reimbursement later on, though it is related to this as well. Some of these pieces fit kind of together. So when we look at these different pieces, it's really elevating that when we think about moving this policy into actually processes at your organization, there are things that might need to change that people need additional resources and support. So folks elevated, you know, when I enter things into my electronic health record system, there's literally not a way to do an intake in my electronic health record 5 times. That is impossible. And so what am I supposed to do? Like, how do I change that so I can capture what I'm doing? Folks highlighted things like the questions that are a part of your usual assessment process don't always translate. So folks shared like, I have to have safety questions, and I don't know if it's appropriate to ask about suicidality of the child. Like, what am I supposed to put there? Like, what am I supposed to say? So a lot of these pieces tied together around thinking about actual like systems and documentation and what are the things that we should be doing, and how does that translate with the DC 0 to 5 in terms of their axes. So if I collect the information around relationship, where does that actually go in my assessment? So a lot of these pieces are interrelated, but one of the ones that we've heard over and over again quite consistently is around a specific assessment process. And this isn't just the questions to ask, but how do I actually structure those 5 sessions? Should I be observing the relationship first? Should I be doing like the background information? Should I be doing caregiver only sessions? So there was a lot of interest in understanding what folks could actually put into practice to make this a real program. I will note that electronic health records, the reason we have the coins here is to recognize that although some agencies might have homegrown EHRs that they can manipulate and remodel for themselves, a lot of times these also take partnership with external providers that actually have to reconfigure systems, and that takes additional money and costs that organizations might not have to update their system to work for young children. This last box, the pinkish purple one over here, is really about screening, assessment, and observation. Our participants highlighted how this is critically important to part of the assessment process. And there was a whole host of things that we've heard about this. One of the key things that I think is worth noting is that folks talked about, like, what are culturally appropriate, developmentally appropriate screening tools? Like, what should I be using with this age group? And a lot of conversation about what does it mean? Is that to identify needs? Is it to monitor progress? So a lot around how do we think about screening and assessment and observation, and how that is an integral part of our work. Kiki, I'm just going to pause to see if you have anything to add about this piece before I keep going.
I don't think so. Beautiful summary.
Awesome. Thanks, Kiki. We will transition then into mental health treatment with young children. And before we dive into, some of the pieces that we can think about for improving our system, I think that the part that's really important to highlight on this slide is that providers that we connected with over the summer really highlighted a strong recognition and awareness that when we talk about mental health treatment with young children, we are always thinking about their relationships and their caregivers, and that it is critically important to not just be seeing a child in a silo, but to really be holding the caregiver and bringing them along as your partner and as a part of that treatment process. The other piece that I think is worth noting on this slide before we dive deeper is that we put the definition up here that I think we pulled from 0 to 3. I can't really remember at this very moment, but that mental health treatment, our aim is around really to be helping to address distress and suffering and return to healthy development with supportive relationships. And I think many people on this call probably know this already. And we heard from folks, there is still a misunderstanding and misconception out in the broader community that folks are afraid that treatment with young children is aimed at medicating children or about stigma and like hurting children, and that this is going to follow them and that it's going to actually put them into a system that they won't be able to get out of. And so this is just important as we continue to think about awareness about infant and early childhood mental health, that though we might see it as a very supportive and helpful thing to be promoting, that there are still some folks who don't understand and are fearful. And so there's a lot of work to be done around awareness and partnering to bring folks along. Next slide, please.
And I'll just add that this may come up later, but some of that fear or anxiety may come from real experiences that people have had. And so we don't want to downplay the fact that people are coming with these anxieties, but actually recognize the harm that has been done, hold space for them, and move towards healing.
Thanks, Kiki.
Which our next slide goes into.
Exactly. And I hear that my sound might be not okay, so please let me know and I can try to adjust things sometimes. In that spirit, we also wanted to highlight the ways in which we heard about centering equity and really thinking about how are we bringing people along and how are we also thinking about different ways of knowing and healing. A lot of our participants highlighted the critical importance of thinking about cultural match between staff and families. This might be ethnically, this might be linguistically, it might be, having folks who have experience as a parent themselves. There's a lot of different ways of thinking about cultural match, and also just elevating how are we thinking about ensuring that families feel supported and heard and represented in the spaces where they receive care. We also heard a lot around outreach and education and the culture of community, this being really a piece around reaching out to folks in ways that match for them and that can be destigmatizing and actually create an avenue to a path of healing. So instead of expecting folks to come to us and to come to our sometimes not super welcoming buildings, to go out to the places that these communities are and to connect with them in spaces that are safe and to learn about their cultures. We also heard a lot around cultural-based practices for healing, especially from our tribal partner participants, around the critical importance of us really thinking about what is healing, what does promote connection and community, and how do we foster resilience in a way that is meaningful for the folks that we're connecting with from their cultures and communities. Next slide, Kiki. We did hear that there's still needs in this space. So providers, really elevated that one of the key things that they need to feel equipped to better support young children is around training and professional development and dyadic treatment models. The little box in the corner, you'll see that we have a little bit of information about evidence-based practice and dyadics models. In 2019, there was a survey done in partnership with Perigee that identified that fewer than 10% of the respondents had formal training in any infant and early childhood mental health EBPs. A 2022 survey indicated that less than half of the behavioral health agencies that are offering care to young children are providing dyadic treatment. This is important as we think about training and quality services, that folks really elevated that they don't feel comfortable working with kids this age group if they don't have the tools in their tool belt to know how to effectively provide care. Other tools in the tool belt that came up were around developmentally appropriate spaces and materials and on-site childcare. These are pieces that might have additional costs when we think about the buildings that we use. Oftentimes, these were not designed with young children and their families in mind. This might mean that we come into spaces that might not have, friendly colors that are more appealing to young kiddos. It might mean that there aren't chairs that are small enough for kiddos to sit on, or toys might not be available to use in the waiting room or in your session. And thinking about on-site childcare, this has a lot that we could cover in terms of on-site childcare. This isn't just about being able to have a place for our siblings to go while a child is in session with their caregiver. This might also be just somewhere that you could drop your kiddo that's a client into the childcare space because a parent has something coming up for them during the session that you need to support them separately. And so this is often an additional cost, not just to space, but to staffing and to thinking about liability and things like that. And so folks were just elevating, if we want to do this work well, what are the pieces that maybe are not already built into our system to do it effectively? And with that, we have another reflective question for you all that I will let Kiki walk you through.
Beautiful. Well, these are some reflective questions about both the mental health assessment and the treatment process for young children. So one of the providers asked, what does doing this work well look like? What processes or procedures do people have for assessment and treatment? So if you're someone who has been in the game and you'd like to share, we'd love to hear your thoughts in the chat. Another provider asked the question, what are some specific intake questions for birth to 5 that aren't asked in other assessments? So going back to what Christine shared about the fact that often our intake questions are really designed for adults and older children and youth, what are some things that we may not think of normally that we should be asking when working with young children? And we'll give you some time to put that in the chat, and also just want to call out to the folks who are sharing about the amount of money they've spent on play therapy supplies, the importance of collaboration with families, and developing a birth to 5 intake assessment template that might be helpful to others based on the DC 0 to 5. And as you guys continue to share in the chat your reflections, I will move us along to the next slide. Does that sound good? All right. Let's dive into providing services in home and community settings. This section of our report, well, it got its own special section. We asked questions about this primarily in the beginning because we were trying to understand implementation of the mental health assessment for young children, or MACI work, which created a new reimbursement system to really support providers in doing the assessment in home and community services. We heard from folks that this was challenging for a number of reasons, and so this is an area we really wanted to understand through the tour. And through the tour, we learned a lot from people about how important it is to think about providing services in home and community settings, not just during the assessment process, but throughout the whole course of treatment and intervention. And oftentimes those things can't really be separated because you're not going to build a system maybe just for 5 sessions or just for 2 sessions. Organizations are thinking about how do we build a comprehensive system for this support. So that's why you'll see this kind of bridging across assessment and treatment. That being said, for folks who are doing services in home and community settings, we heard about a lot of different practices that they put in place to ensure provider safety and comfort when they're going out to the homes, when they're going out to Boys and Girls Clubs, they're going out to McDonald's, the parks to meet with families, because it is going to look different than being in an office. Starting with screening clients for safety concerns before going out there, having written guidance and policies that providers can go back to know about what does this look like, what does safety look like, what do best practices look like. Having specific check-in policies for when staff arrive at locations and come back to ensure their safety. In some cases, doubling up staff, so sending 2 staff out to a site to ensure their safety. Providing staff with phones, in some cases satellite phones where there isn't good service so that they have a way to connect with each other or with their supervisor if something's going wrong. And then lastly, specific training on home visiting. Safety was one of the big things that came up, but it's not just about safety, it's also about your comfort and your ability to meet families where they're at in their natural environment. I love this quote from a provider. It's a whole different thing to sit on a pile of laundry or wonder what is that smell and still do your therapy. So this is something that some people are going to come with natural gifts for, but it's also an area where people can build their strengths over time when they have training, support, and professional development. So that was a way that people were really building the skills of their staff in this area. Aside from provider safety and comfort, the big thing we heard was the cost. It costs money to do this well. This is another quote that I just love, that people said, it's evidence-based that home visiting has a huge benefit, yet it's higher, it costs more, it's all at odds. We asked some questions specifically about when people are looking at the travel reimbursement policy for mental health assessment for young children, which is, narrowed just to that assessment process. And some people shared they weren't aware of it, they didn't know it was there. They shared that it was complex. You have to fill out this paperwork, you have to submit it to each MCO, you have to wait for your payment back. And people also shared that the money that they were getting back wasn't really covering the cost of what was going on. The reimbursement is really just for mileage costs, and it doesn't take into account the loss of provider service time. And when we talk to people about the broader perspective of home and community services, not just in the assessment, this came up again that, mileage reimbursement is a cost, paying for car insurance and those things are a cost. But the big thing, the most expensive thing is that loss of provider service time. You're going out to visit a family in a rural area, you might be driving 2 hours there and 2 hours back. And that's, potentially 4 clients that you're not able to see because you're in transit. And so providers really struggle to reckon with how can we do this best practice of seeing communities where they're at when we're trying to manage, maybe our productivity standards that we've set or manage our costs. And so this was definitely a challenge that people shared that they experienced. And I will say that it was promising, even though this was a challenge, it was helpful to hear other providers know that they weren't alone in not knowing how to figure this out, but also in hearing that there are some people who have figured out a way to do this, and that there are models that they can build towards. Anything you'd add on home and community services, Christine?
I'm sorry if this is a repeat, Kiki. I think one of the things to just highlight too that we heard that I think is just like also, it sticks with me whenever we talk about this topic, is folks talking about the potential harm of starting in the home and then making folks come to the office. And so that's not represented on the slide. And it wasn't like a huge theme that came out on and on again. And just recognizing as we think about these innovative ideas, what are the potential unintended consequences? And folks saying like, sometimes even if I could do it, I don't want to because I don't want to set the family up for expecting it to be one way and then changing it on them. And so I elevate that as just a piece too to hold of these other aspects that our participants really are holding and thinking about as they look to, think about their care. So thanks, Kiki.
Well, speaking of caregivers and centering them in our practices, we do have a whole section of the report that's talking about how do we work with caregivers and families in a way that is strength-based and that is relationship-based. This is one of my favorite parts of the statewide tour, was hearing providers talk about all the really unique and innovative ways that they really are centering caregivers and families in their work. Some of the things that we heard were peer support, either through certified peer counselors, peer specialists, or caregiver groups where caregivers are learning from each other in a group setting. Involving all the caregivers in the child's life. Sometimes this came across as people talking about, maybe the mom came into service, but we're doing intentional work to get the dad involved. Other examples might be, okay, we've got grandparents, auntie and mom and dad involved, and maybe foster parents and kin parents and bio parents. And that is a lot to handle, but we really value making sure all of those caregivers, because they each have a unique perspective on the child, are part of this work. Education and outreach, so intentionally going out to communities, going out to parents, going out to families to say, hey, did you know this is available? Did you know this is something that could benefit your family? And lastly, these family-centered and relational approaches. So treating the caregiver as a primary part of the relationship and of the work. This isn't really that different from what Christine shared in terms of the importance of this dyadic relationship-based work. But we heard from providers that this approach is, not only a best practice for helping young children return to healthy development, but it's also a really powerful strategy for parent engagement. When parents feel like they're being treated as important, they feel seen and heard, and they want to engage. The last piece that people highlighted is that, we're all going through stuff, and families who are being served through our Apple Health system, have mental health needs, they may have other things going on that can get in the way of accessing treatment in a way that we're like, well, duh, just show up for your appointment. And so providers shared about all the different strategies that they put in place to kind of reduce those stressors and increase the resources that parents have to get to the mental health services that they're interested in. So things like case management services, connecting people to resources outside of mental health, flexible funds for concrete support like meals, childcare, transportation, providing referrals to allied services. So saying, hey, I heard during the intake that maybe you might be interested in your own mental health treatment, or it sounds like housing is a stressor right now. Here's how we can connect you to those housing supports. We'll talk a little bit more about those allied providers in a second. Offering evening and weekend hours, recognizing that folks are working in school, in childcare, and so 9 to 5 may not be the best time for them. And then having these client-centered no-show policies. So knowing that parents are gonna have stressors, there's gonna be things that come up, and how do we work kind of acceptance and support of that into our agency policies where we're trying to, run a business and get things done. So that's a tension that people have to walk, but trying to center the caregiver in the midst of that was something that people shared was important to them. There were some ways that people shared that they see opportunities to strengthen caregiver engagement and involvement. One of the things that people shared as a top desire was strengthening the awareness that parents, caregivers, and communities have about these services, what they mean, what they can look like, and how they can access them. People also wanted more training and support about fostering buy-in for that ongoing participation. So like Christine shared, that assessment process, parents might say, well, I want to get started with treatment right now. I don't want to wait. And how do you have that conversation with a parent to help them understand why this might take longer, or even why we're not just seeing the child in the room by themselves and the parent is off somewhere else, but we're actually seeing them together and helping parents understand why that might be important for this stage. Addressing financial and logistical barriers, people have creative solutions around this, but it's still not something that's always easily solved. And building capacity for allied services. We heard in some communities they just don't have access to the allied services that families may need in addition to mental health. And so there's opportunity to build on those and increase the resources that are available to folks. Anything you'd add here, Christine?
Thanks, Doug. You're doing great, Kitty.
Is this one still me, Christine?
Oh. It is, but if you need a break, I'm happy to hop in.
No, I'm good. I'm on a roll. Okay, collaboration. So as we talked about allied providers, when we're thinking about the workforce, you know, we focus on this tour on the mental health treatment providers, but all of these other folks that are surrounding young children and families are crucial to their thriving and well-being. So we heard from a lot of providers who have been doing this work that collaboration is essential. So they're thinking about what are the other needs that might come up in the assessment and treatment. And people also sharing about how their services have a team-based approach. So they're intentionally working with the other providers, pediatrician, occupational therapists, childcare providers, educators. And that approach is really helping them all to have a whole child, whole person, whole family well-being model in mind, and with the added benefit of lower turnover in staff. People shared some of the concrete strategies they have for building partnerships, like going to collaborative meetings and regular networking with folks, actually initiating those referrals, and when they're initiating referrals, doing the warm handoff. So there's a connection between the providers who are then holding the parent as they may transition from one provider to another. Our favorite ROIs, releases with information, getting that paperwork done, getting the signatures done so you can share information easily, effectively, and with the consent of the family so they understand what information is being shared. And then care coordination and co-located services. So a lot of times we heard about people offering home visiting and infant early childhood mental health in the same place, or early childhood education and infant mental health in the same place, and having those services in the same place actually helped the family because they only had to go to one location, but it also helped the providers to learn from one another. There are still some challenges that folks are experiencing when working across these different disciplines. The greater cross-system understanding of what infant early childhood mental health is and the best practices for addressing it. So folks who might be more in this world, seeing in their provider partners, maybe we could build some more knowledge and skills around what this looks like for a young child. The fact that, you know, 3-year-olds could have a mental health diagnosis, and this is something that could happen, will help to improve that collaboration. Earlier identification of mental health needs, which is kind of related to this understanding piece. I love this quote from a provider about people waiting for the wheels to come off before referring, especially for children of color. Provider starts working with the child and says, "Where have you been, my little person?" So there was this opportunity for earlier intervention if someone has been able to pick up on it. And if we can build that cross-system understanding, we can get families to the care they need earlier. Folks did share there were sometimes challenges collaborating with allied providers during assessment and treatment. So during that assessment process, you're trying to get the collateral information about, you know, did they do an ASQ? Did they do a developmental screening at their pediatrician visit? You know, what is stuff looking like in the child care? What's the history of this family with child welfare? And so the work that goes into reaching out to those allied providers and gathering that information can be tough. You know, all these providers have their own schedules, have their own work that they have to do. And so what are some of these workflows and streams kind of on the left side of the screen that people can put in place to make that a smoother process? And lastly, one of the things that folks shared as a top desire was up-to-date information about available services. So in your region, in your area, who are the people that you can refer families to for mental health services or for housing services or for occupational therapy? And folks shared about, you know, if I've been in the community a long time, I might know those people through personal relationships, and those relationships being really key to building systems. But if there's turnover or there's change, sometimes that information and that knowledge can get lost. And so having a place where people can go for up-to-date information, not losing the importance of relationship building, but having that as a supplement was something that people were really looking for. Anything else you'd add here, Christine?
No, ma'am.
Well, let's dive into some reflective questions, and I'll turn this over to Christine to get us started.
I think folks have already got us started in the chat with Malia and Melody sharing and uplifting their experiences in the parent and peer space. And so thank you for getting us started. So the first question here that was elevated from one of our participants is around how do you integrate early childhood education and infant and early childhood mental health? Thinking about some of our consultant friends who are on the call. For prevention and intervention, how do we make it all work together? We also elevated this question. This was not from providers. This is more us kind of coming up with a second question that we thought might be helpful, knowing that there's folks here that might not be mental health professionals themselves. And so what are some of the opportunities in your current role to fostering caregiver engagement and allied professional collaboration? And so please feel free to share these in the chat. I think Malia and Melody getting us started and kind of recognizing the opportunities for parent peers as connectors and thinking about the parent-to-parent system that helps kiddos who might have an identified disability are really good examples of ways that we can start thinking about integration and coordination. And Kiki, I think I get to talk about the thing I'm sure everyone is most excited to talk about, financing.
Dun, dun, dun.
I think it'll probably be unsurprising to folks that financing, funding, reimbursement was a key conversation throughout our sessions. And often the items that are in this section of the report touch on a lot of different components of the report, like workforce, in terms of compensation and thinking about reimbursement for treatment. And, you know, at first we were like, maybe we just integrate this throughout. And eventually we were like, I think that this needs its own space for us to really think about and hold the challenges and opportunities when it comes to financing. When we look at this space, I just want to recognize that what I say about this slide is also true for a full spectrum of infant and early childhood mental health services that are not mental health treatment specific. So the pieces that are highlighted here around infant and early childhood mental health financing relies on private philanthropy funding. A lot of times there's often grants through the state or federal programs. There's things that are covered and not covered by commercial insurance and Medicaid. So it's a very complex system that often relies on a lot of blending and braiding. And there's a lot of opportunities for us to think about how that's working or how it isn't working. Folks really highlighted that when we think about the financing model, often what's funded is what drives what we can do. And so folks really highlighted, like, if I have a grant application and it allows me to only do this, then I'm trying to like kind of fit things into that model instead of being able to do what I think is best for families. Oftentimes folks had innovative approaches where they found different ways to leverage funding to fill those gaps. But a lot of work is being done at a provider and agency level to try and make funding, their programs fit into funding instead of funding supporting their programs. And so this section is going to focus more on the mental health treatment components, but is definitely relevant as we think about that full spectrum of multidisciplinary services across that promotion, prevention, treatment continuum. Kiki, next slide, please. A key piece that has come up a lot, and Kiki and I were very not surprised to hear this, and we definitely talk about this a lot even during our billing webinar, is that we have a very complex system when it comes to mental health treatment and the funding that supports it. When we look at how it's all working, this little spinny over here, some of the key challenges is that we have a very burdensome system. Folks are elevated. It's hard to know how to get enrolled. Sometimes what you ask for is different than what this other insurance provider asked for. They also highlighted, like, there's 5 MCOs and multiple commercial payers in our state, and they don't all expect the same thing. And so providers really highlighted the hoops that they feel like they're jumping through to try and understand what they can do for which plan, for which child and family. A piece that's really important around the administratively burdensome part, which was highlighted as a top desire, is that it was also elevated that this isn't just, it doesn't just cost time. There's also a financial cost to having to resubmit claims or having folks spend time having to like navigate and figure out, decipher what's going on. And we also highlighted in the report that there's psychological cost to this and emotional cost. This can lead to burnout, and it impacts our providers in being able to continue to maintain being a part of. Another top desire was to better understand Apple Health Medicaid billing. Folks just talked about, like, when we don't understand it, we just don't bill it. So there's potential money left on the table because folks feel nervous or anxious about, what if I do this and then I get audited and it gets taken back? So it feels safer to just like, we'll figure it out, and to not even go through that process. One of the things that was great to hear for Kiki and I is that folks have found some of the resources that we've developed to be helpful One of those that was named was the Apple Health Infant and Early Childhood Mental Health Toolkit, which talks about like, what do you need to do to get started as an infant early childhood mental health provider for Apple Health in Washington. As a very self-indulgent plug, it also now has best practices around infant and early childhood mental health. So I encourage you to check it out. But it was great to hear from folks that tools like that our team is trying to develop in response to the questions and challenges they're facing have been helpful and folks better understanding and demystifying this complex system. Kiki, is there anything else you want to add to this one before we jump to the next?
I think one thing that we also heard that was really promising was people talking about the importance of collaboration between clinicians and providers, and then their like billing and coding staff, and how important that collaboration is. Because if you're the person on your team who's like really rah infant mental health and you want to get this started, but you don't have a coding or billing background, that disconnect can be really challenging. And so there's a nice parallel process here, honestly, when we talk about allied professionals and the importance of cross-disciplinary supports for families, is that we need cross-disciplinary supports for providers in getting this work done. And so one thing that has really been helpful for people is when both their clinicians and their like administrative staff are learning the same thing together, and then working together on how to implement that. And so that's something that Christine and I have also been really passionate about in our work, is when we're designing billing materials, we're trying to say, hey, the audience for this is both the clinicians and the administrators. We're trying to make sure you all have this shared information so you can partner together on this work. And so that was really affirming to hear from folks that, yes, that actually is a strategy that can be really helpful, though of course does require kind of breaking down silos and working on collaborative strategies to get to a place where you're not duplicating work, but you're really building on each other's work.
Thanks, Kiki. I'll try not to wiggle, everyone. I know my sound is still being funny. I'll try to stand still.
I told you, I was like, Christine, stop swaying back and forth. It's impossible.
Sorry, we also heard some other pieces that are impacting the sustainability of infant and early childhood mental health services, in particular treatment services again. Three of the major buckets that were highlighted that are important for us to think about is, the first one was folks talked about program and operating expenses. So thinking back to, I need to buy so many toys to do play therapy, or we're trying to offer childcare, or we're trying to offer concrete needs and supports to families. Those things are all things that cost additional money and are not necessarily always covered in the current reimbursement model. Beyond that, people also talked about, so let's say I want to hire someone to specifically do this work, and it takes time to onboard them, for us to build up their caseload before we even start to bill to Medicaid or other insurance. And then I actually don't recoup that reimbursement for some time because it takes a while to get paid. And so folks highlighted, I would either have to be able to function in the red, so at a cost where I'm not making money, or we would have to have a reserve to cover that to even get started. And so it was really important for folks. They were sharing that, I might want to do this, but how will I do this if I don't have those startup costs covered? Another piece is around service-related time assumptions. This kind of goes back to the travel piece, but it also in thinking about like productivity requirements. And there was someone who talked about like, I can't rush a tantrum. Like there's some things that might not necessarily be inherently billable all the time that might impact the time that you have for care. Or it might also be that even if I can bill for that, it's not going to be an enhanced rate for that extra extended time. And so folks just really highlighted like our current models for identifying what rates we pay for services might not be representative of the true cost and time to do care when working with young children. This last one here, the purple, I think is also really important. Though grants and private funding were elevated as an innovation that folks have identified as ways that they've, supported families and made sure that they're offering developmentally appropriate care, it was also highlighted that it creates some instability in being able to sustain their programs, because you're having to go through all this effort to apply and to get the funding, and you get things started and then it's ending, and you're having to now either resubmit or find a new funding source to cover it over time. And so this kind of roller coaster effect of like getting funding and then losing funding was also highlighted as a piece that just makes it challenging to really sustain programs and workforce. Next slide, Kiki. And so one of the things that was highlighted as a top desire from folks was really about how can we think differently about how we pay for infant and early childhood mental health services. Alternative payment models, or APMs, are these ways of thinking about how we pay for things differently. The Centers for Medicare and Medicaid Services have become really invested in alternative payment models over the last decade or so, especially value-based payment, which is essentially paying for quality over volume. And alternative payment models aren't about creating new programs or new services. It's really about how can we think differently about how we pay for the care that's being provided, and really thinking about does it make sense for how people are doing their work and what we're trying to pay for, or not. And so this quote here, I think, it goes hand in hand with folks saying that the financing drives what we can do. And this quote, I think, really highlighted that folks are saying, let's think about what providers are actually doing in practice, and let's hear from families about what they actually want. And rather than us trying to fit our models into what funding is available, why not create a funding model that fits our program? So I think that's really powerful for us to think about as we move forward as a system, not just for mental health treatment services, but how we provide care generally. Kiki, is there anything you want to add before we transition to reflecting for a quick moment? Awesome. And so one of the questions that was elevated that is really important for us to think about as we continue to think about what are we paying for, how are we paying for care. We had a participant highlight that, the marginalized are staying marginalized. And so as we think about our funding, how can our funding systems change that? And so we certainly we don't think that this is an easy question to answer. And as you all reflect on your work and the communities that you serve, we certainly welcome your insights and reflections about what needs to change and how our systems are funded to really address those who are underrepresented and marginalized in our system. And so I'm going to just give us all a moment to just take a quick breath and think about that before we move on, because I think it's important. Thanks, Malia, for getting this started in the chat. Kiki and I, we've covered a lot, and we're about to make a transition for you all, and we're doing good on time, so we might actually have time for questions with folks as we move into next part. All of those pieces that we highlighted for you all were really the voices of providers and the perspective. I know we were talking in the chat about some things not being represented, and Kiki and I tried our best to not influence what information came into this report, but to really reflect on what folks were sharing with us. This next section of our presentation are things that Kiki and I did develop in partnership internally and with other agency partners to think about what we can do to move forward. And so with that, Kiki, is there anything you want to share about this before we keep going?
I don't think so.
Awesome. Well, let's look into moving ahead. So I share this one before even diving deeply into us thinking about HCA's priorities in this space to just elevate what we've really been talking about throughout, which is the fact that our system is complicated and it's confusing. And there's a lot of different people from a lot of different trainings and backgrounds supporting this population in particular. And oftentimes providers and communities are left to translate on their own whether or not things fit together. And so in an effort to try to demystify and create greater integration and coordination, the priorities that we're going to talk about on the next slide, we wanted to highlight that we did partner with King County Best Starts for Kids, with our partners at the Department of Children, Youth, and Families, and with our partners at Department of Health, to look at our different plans that we all have existing for this space and to say, how does this fit together, or are we all doing completely different things? And although these different priorities and plans are not a one-to-one, we have different populations of focus, we have different disciplines that we're supporting, we use different language, and we have different scopes of practice. There was alignment across these priorities that fit pretty well together across there being kind of 5 big buckets. And so I elevate this before we talk about our priorities to say that though we're sharing HCA, infant and early childhood mental health priorities, that we see these as inherently connected and related to the work of other state partners across the state. And this is an effort for us to try and do the lifting instead of making others jump through hoops to figure out what we're all talking about. Kiki, next slide. So with that, HCA's infant early childhood mental health priorities are newly launched as a part of this report. The biggest piece of this was really building off from what we heard throughout the report. So these priorities were an effort to say, what did we hear and what does that tell us about what we need to focus on in our work moving forward? And so the voices of providers and community were really at the center of us thinking about where we go next. As I highlighted on the last slide, we also partnered with sister state agencies and Best Starts for Kids around this as well. And we also wanted to make sure that this makes sense and that it's grounded in our broader HCA strategic plan and that the language was representative. And for us, what was really great is that a lot of what's in our strategic plan, it's like, how do we just do this for young children? A lot of it definitely fit, but making sure that we're not just carving something out within our agency, but that we're just strengthening what our commitment is already in our agency for this population. Our 5 priorities. Priority 1 is really around strengthening and supporting a diverse infant and early childhood mental health workforce. And when we highlight this piece, though the report was really focused on mental health professionals, this commitment in priority 1, we recognize that there are a lot of healthcare providers that are a part of the infant and early childhood mental health workforce, that it is our priority and responsibility to be partnering and thinking about how we support them. With priority 2 around ensuring equitable access to developmentally appropriate services for young children, this similarly to number 1, we also have work in supporting pediatrics and supporting services that are for, occupational therapy, speech therapy. And so really making sure that we're thinking about how kiddos are getting access to that whole spectrum of care that they need to thrive. Priority number 3 around building person and community-centered systems. I think this report is a good step in that direction, and I think Kiki and I try to elevate that in our work in general, but just a commitment to continuing to check in with communities and providers to make sure we're thinking about how is our system working. And also recognizing there was a question early on about were families a part of this tour. This priority also is in recognition that we have more work to do with families to make sure that what we're doing is also centered in their needs and their priorities. Priority 4 is really around us thinking about our payment levers and our program levers to support quality services that are sustainable. And so a lot of this around like data-driven approaches, but also again, making sure like, do our payment systems make sense? Are they working? Are they achieving what we're looking for? And then the last priority is really around the coordination. Kiki and I think a lot and talk a lot about parallel process and whether if things aren't coordinated for us and our work with others, how does that flow down to families? It makes sense why others might not feel like it's coordinated if we're not at the top making sure that we're working together. And Kiki, do you mind going to the next slide? These are not all of the things that HCA would ever do to support these priorities, but it's a start. And so we also thought it was important to give folks concrete examples of things that we are committed to doing to respond to this report and the priorities identified. And so in response to the report, a need to support a diverse workforce, we are in the process of working with the Barnard Center on supporting a child-parent psychotherapy learning collaborative and also working with our partners at the University of Washington CoLab around how that connects to our evidence-based practice reporting. We're going to continue to work with the Washington Association for Infant Mental Health, which is a part of the ACIN agency, and we'll continue to work with them around ensuring that the things we heard about training and needs is reflected in their work that they partner with us on around the Workforce Collaborative. In terms of ensuring equitable access, we are looking at what are our opportunities in terms of our internal processes or even requests to the legislature to think about our family therapy rates, recognizing that for young children, it's the best practice to work with caregivers. And so making sure that rates are reflective of that, that best practice. We also will be looking at our travel to home and community policies to see how we can address some of the barriers that were identified. And then partnering with the mental health referral service and Help Me Grow around how we strengthen the opportunities for those systems to get folks access to the care that they need. In terms of priority 3, which is really around building that community and family-centered practice in our policies, this is a commitment to continue to strengthen our work with our tribal partners, as well as developing a family-focused engagement plan. I know we mentioned it in the chat already, but we do offer quarterly office hours, and starting in July, we'll have provider spotlights where we invite folks from the tour that shared innovations and solutions for them to share about their processes and what they're doing, for there to be a co-learning space for providers to connect with one another. In terms of using our payment and policy levers, we are exploring options for doing alternative payment models, in terms of the infant and early childhood mental health treatment space, but also thinking about pediatrics and well child visits. We are currently doing an evaluation on our Macy program, our policies, to say, like, is it working? What do we need to do? What do we need to change? And we will continue to partner with our managed care plans on how is this working? Like, what do we need to do together to strengthen our partnership and demystifying, but also like making things clearer for providers who are wanting to do this work. And then in terms of coordination, there's current work underway that Kiki and I already participate in a lot of convenings, but Kiki was also a big part of creating a cross-state agency meeting where folks from our sister state agencies, anyone who works on pregnancy, infancy, early childhood work, come together for us to be sharing resources and thinking about how we can integrate and coordinate across our programs. And we will continue to look at some additional information. Things came up during our tour around like child welfare specific, or ESIT, early supports for infants and toddlers, and pregnant and parenting women. And those are not reflected in the report, as that wasn't the primary focus. But we will be analyzing that information to then partner with the folks who specialize in those areas to think about, are there additional action steps we need to take to support those specialty populations and programs. Kiki, that's a lot. Is there anything you want to add to the things we're doing?
Ooh, I don't think so. I mean, you can see here that there is a lot that we're going to be working on in the next few months, and I hope that this helps to communicate to folks how dedicated we are to this work, and that we do often take a very stepwise approach to systems change, not changing the whole system overnight, but making little steps over time. But that you all know, as our community, that you can hold us accountable to these action steps, that, you know, we want to recognize there are power differentials working at state agencies, being a provider, being a parent, but that this report and the way we framed it is one step that we're trying to take to say, hey, we're part of this community with you, and you can hold us accountable to these important ways that we're going to try to repair relationships and improve things for families and communities in the future. So super excited for all this work to happen, and can't wait to partner with many of you on it.
I think with that, we will turn it to a question for you all. We only have 2 more slides after this for us just to share some additional information. And so I do think that we do have a little bit of time if folks are brave and want to come off mute. But, you know, when we think about this work, we also wanted to not just have like, what is HCA doing, but we also wanted folks to feel like there are actionable steps that they can take. If you turn to the report, there is a summary that collects all of the taking action steps throughout the report for the different topic areas. And it's categorized by individual, by agencies, and by systems partners. And the reason that we did this is that Kiki and I often hear from folks that they don't know what the first step is, or they feel like they're trying to like boil the ocean. And so just tried to provide resources for folks to think about steps that you can take, whether you're an individual or you're a part of leadership at an agency or you're a part of the broader system. And so we would love to hear from all of you around if there's steps that you plan on taking to support this work, or how you plan to use the report, or what you hope comes from it. So feel free to add in the chat, but if anyone's brave enough to come off mute, we certainly would be happy to hear from you. And if folks do not want to come off mute, I know that that was not said that we would do that, so you do not have to either, but we would love to hear, at least in the chat, if you feel comfortable around what you might be doing for next steps for yourself, or things that you hope come from this work.
I can come off mute. I put in the chat that my area of focus is perinatal mental health, but so much of this report just resonated with the systems challenges that we have in building better support. I'm in Whatcom County, and just we have a local perinatal mental health task force. We get some funding from private funders and also from DCYF and our local behavioral health fund, and trying to use data from DOH and connecting with the HCA. And I was really excited to see the cross-agency work. And I had sent something to Kiki that I just really wanted. We get this funding from DCYF, but we don't always have good county level data to help us know, are we turning the curve on how we're using these funding to apply the strategies? And that feels like a great place for state cross agencies to make sure that the funding sources match up with the data that we can look at.
I like that. Thank you so much, Allison, for being brave and speaking up. And I have a hunch that you might have connected with our new perinatal mental health program manager recently too. And if not, let me know and we can connect you, because I definitely think we have opportunities in the perinatal space too. Yeah.
Yes, yeah, definitely. In fact, I was going to draft an email, a follow-up email to her today.
Love it. And thank you.
Just wanted to read out.
Yeah, go ahead, Kiki.
Read out from the chat some of what folks are sharing with their local health districts, which is really exciting to hear, because this information, and there's a little bit more about this in the report itself, really does come from every region of the state. And so there is a little something for everybody. Christina shared she's going to be using it to help answer the question, what are the things we need to consider as we build a system, which is really beautiful and exciting for us to hear that not only will this report help reflect back what we heard, but can also help others learn from each other and build on that knowledge and wisdom. In a response from Tina about more research and collaborations mean better advocacy for this field and the children and families that we serve. Beautiful, Tina. Wendy's going to send a template to Christine and myself to distribute it. Beautiful. Well, keep these coming in the chat. I know I am sometimes a slower processor and need more time to think. So while we're here, we'll move on to our other slides about kind of wrapping up, but we do have until 12:30. So as folks continue to put things in the chat, we can come back to that piece too. Let's see if I can get this to work. Okay, well, if you feel like you did not get enough information today in this hour-and-a-half long diatribe, good news. There's even more in the 115-page report. We have more information for data nerds out there about our approach and methods. So if you're curious about how did we reach out to folks to invite them to this event, who did we partner with, what regions were people from, what sort of agencies did they work at, we have more of that in the report, as well as hearing from participants about what this experience was like for them, which was a really powerful thing to hear. And I think, even though it's not on the screen, I want to highlight how many folks shared how meaningful it was to be in community with each other. That sometimes this work can feel really isolating because folks may be the only person at their organization who focuses on this, and knowing that there's others out there who care about this, even if they care about it in the way that they're like, I care about this and I don't know what to do, was really helpful for folks in feeling more excited and more ready to dive into this. There's power in numbers. And so I think Christina and I reflected a lot in the moment at these events about how meaningful that was to us, that we got to partner with folks on this way to be together. We have more detailed information from our claims data about what MACI implementation looks like. We also have examples from providers about what they're doing in terms of their assessment process, what screening, assessment, and observation tools they're using, and what evidence-based practices they're using. This is sometimes a common question we get from folks, is what are other people doing? And sometimes people will frame this as like, what should we be doing? And oftentimes it's not really our role to tell you what you should be doing, but we do want to offer an opportunity to share back what we heard from others that they're doing, so you can do the research yourself to figure out if that's the right fit for you and your organization. And lastly, there are resources galore throughout this report. Christine and I are big fans of kind of weaving the web, and here we're talking about our thing, but oh, look over here, here's another connection to another resource that either supports or kind of complicates or builds on the work that's happening here in Washington. So we've done our best to highlight different organizations, different researchers, different data points, different briefs and papers and guides that can really build on this. And we've linked all of those in the report as well, so that if you get to the end and you're like, wow, there's a lot here, you have one place you can go to see everything that's been referenced in the report to get you started. And if you feel like you haven't heard enough from us today and you want to learn more, we have lots of ways you can stay in touch. You can visit one of our websites. You can find billing resources on those websites. You can sign up for our regular emails as well as our monthly newsletter. You can join us for office hours, which will be starting back up actually in April. And as a registrant of this webinar, you'll be one of the first to get a link to that event. And if that time will be a great place to offer, it's been a month since maybe you read the report and you saw the presentation, what questions are coming up for you that you either want to ask us or you want to ask other folks in your community. And as always, please feel free to email us. Oh, perfect. Christine put our emails in the chat. We may not always have the answers to your questions, but we do love to connect with you and hear what they are and see if we can find a way to connect you to the right folks. And that is it for today.
Oh,